Excellent, and welcome back, ladies and gentlemen, to another episode of The Edge of Healthcare, Lessons from Leaders to Use Right Now. I am thrilled beyond recognition and measurement of the guest that we have today, and I'd like to thank the Academy, the French Foreign Legion, faculty, members and guests, the student body, because this is without ado one of the most anticipated episodes, and we have a lot to cover and a lot to get into. Let's get into it right now with our guest, Dr. Eric Bricker. Dr. Bricker, welcome.
Hey, thanks everybody for having me, and thank you, Martin, as well.
The pleasure is mine. And one of the things I love about healthcare is the many intersecting routes of not only career paths, but just the individuals that you get to meet. And as I was mentioning to you earlier, I was unaware of A Healthcare Z until one of our prior guests, Ron Irwan, who is the co-founder of De Facto Health, spent a long time at CAQH, mentioned that you were the individual that he would like to sit down and chat, shoot the breeze with an adult beverage and kind of get inside your head. I then did a copious amount of research, have since subscribed to A Healthcare Z and tried to watch as many videos as possible. And I will tell you, the Energizer Bunny couldn't keep up with the amount of content that you produce. It is, you're too good. It's impossible to keep up with it. So my applause and admiration and accolades and appreciation to what you're doing. But I want to go back a little bit to, prior to A Healthcare Z and kind of talk about why did you pursue medicine?
Yeah, well, thank you, Martin, for the question. And so I originally had an interest back in the 90s when Bill Clinton was president and Hillary Clinton was going to, Hillary Care and, all this sort, healthcare was going to be, fixed. And I don't have any doctors in my family. And so every doctor I talked to, I was a teenager at the time, said, whatever you do, don't become a doctor because the government, insurance carriers, HMOs, ruining the practice of medicine. And so I said, okay, well, let me kind of learn more about that side of medicine before I decide whether or not I do want to be a doctor. And so I actually started out, somewhat of a similar background to you. I started out at a revenue cycle management consulting firm right out of college. And so I had no idea what it was or anything like that. I mean, I was 21 years old. And so I actually worked in a hospital revenue cycle management for a firm that was acquired by, it was called Stock Ambit Associates. It was acquired by Huron. They actually did RCM for like major academic medical centers, like the biggest places across the country. And a lot of people are familiar with like R1. A lot of the people that I used to work with went on to then work at R1. And in spite of all that, I still wanted to be a doctor. And so I just saw how much confusion and frustration there was on the part of, doctors and hospitals and obviously the patients as well. And so I knew as a physician, I kind of wanted to have a little bit of an atypical career path in terms of not only helping my patients, but also helping them in sort of the larger, financial context and the billing context, because so much of healthcare outside of the actual, care itself is just such a disaster. And if there was some small way I could help improve that disaster, well, then I wanted to be a part of that.
And it's interesting you say that because I did spend probably 30 some odd years provider facing in my healthcare career. And it wasn't until joining Medicare in 2019 that I realized, wow, there's a whole heck of a lot of just complete complexity that's unnecessary that exists prior to the provider-patient encounter. And it is the same type of complexity that it sounds like you were discovering in the 90s from a revenue cycle side. And that's just one component of it. And this is probably a long question with an even longer answer, but it's been 30 years since you made that first discovery. Why isn't it fixed yet?
That's a great question. I was hoping you had the answer.
I'm working on it.
Yep. So it is, it's one of these things where it's not a flaw, it's a feature of third.
Oh,
and
totally.
So at the end of the day, look, we're getting there. And by getting there, I mean essentially the combination of the collection of premium and the assumption of risk and the delivery of care all under the same roof, right? So the best way to fix a billing problem is to not have bills in the first place. And so, essentially, whether people like it or not, the the health insurance carriers are becoming Kaiser, and some of the major hospital systems like UPMC and Intermountain are becoming Kaiser. And so this whole idea of assuming risk and collecting premium and delivering care is, it's slow because everything in healthcare is slow, but it's interesting. Organizations that have done that are infinitely the provider organizations. So UPMC and Intermountain and all the other ones that actually take on risk and collect premium are in infinitely better financial shape than the hospital systems that don't.
It's interesting you say that because I think it was Axios recently had a report this week or last week that indicated, greater than 35% of the hospitals today have a negative operating margin. And that's just not a sustainable model. And when you get back to getting everything underneath one roof, in my opinion, this is a feature, not a bug, but when you have a payer that owns the businesses that determine the amount you're going to get paid, and then they're also the bank that's paying you. And, specifically, you had a great example recently of Interqual got acquired by Change Healthcare, which got acquired by Optum, which is owned by United. So United is the payer in this case, determining the inpatient days of which you're going to be reimbursed and how long that patient can stand or stay there. Seems like we have way too many instances of the fox guarding the hen house.
That's right. And so essentially third-party payment is, in many situations, akin to non-payment. It's like, to your point, that's not really sustainable. So it is, now, it's really become a world of the haves and the have-nots on the hospital system side, where there are hospital systems that are struggling big time, but there's other hospital systems that are just knocking it out of the park financially. So it's really, and that's very typical, right? Because ever since COVID, it's been a very stressful environment, and stress sort of unify the market. Right? So when you mow your lawn, you're applying stress to the lawn so that you only have grass and you don't have weeds, right? So there's not a diversity of flora in your lawn when you stress it. And likewise, when you stress a hospital system environment, you're going to have less of a diversity of hospital systems because it's just going to basically wipe out the weeds. And by the weeds, I mean the small and struggling hospital systems. So that I don't have a crystal ball. I can't predict the future. But that is likely to continue into the future.
All right, so we'll put the crystal balls away and we won't predict the future, but let's take a look at the most recent past. And so we are, as of this recording, we're kind of on the heels of some significant turmoil in healthcare. One, you've got the Change Healthcare cyber attack, which brought almost the entire industry to its knees from one weak chink in the chain. And another one you have is the closing of all of the Walmart and exiting the primary care, Walgreens basically saying, VillageMD, you're done, and recognizing, wow, this whole provision of and delivery of healthcare is hard. So if these giant juggernauts, and I want your clinical take on this and your physician take on this, and the retail side is so challenging, does the independent practitioner look at this and say, how am I ever going to make a living? And their frustration just shows no signs of abatement?
Yeah, so it's a very good topic to discuss, and it's important. Because this podcast is really for people who are earlier in their career, it's very important to understand that because healthcare is $4.5 trillion, it's 18% of the GDP. It's not one industry. It's essentially dozens of industries that are actually very different from each other. Okay, and so what Walmart with Walmart Health and what Walgreens with VillageMD were attempting to address is specifically lower intensity primary care and urgent care. That is not, quote unquote, healthcare in its totality. Okay,
sure.
So it's very important to understand that Walmart Health and Walgreens and VillageMD were not attempting to, quote unquote, solve healthcare. They were addressing a very small sliver of healthcare, which was primary care and urgent care, and it was fee-for-service primary care, urgent care. Okay, so that is a very small niche of the $4.5 trillion. Okay, and so, for example, The providers that are making money hand over fist in the provision of care aren't doing it there. They're doing it in highly reimbursed outpatient surgeries like total knee and total hip replacements, which is why Tenet, look at Tenet Health's stock chart, okay? That is up and to the right, all right? And what is Tenet doing? They're trying to get out of the hospital business and focus on high margin, lucrative outpatient surgery. So guess what? You can make gobs of money being a quote unquote provider in healthcare, but it's in a completely different market segment than what Walmart Health and what Village MD were trying to accomplish. So it's not a question of they were quote unquote unable to solve healthcare. Listen, if you're trying to address primary care, then the economic model cannot be in the fee-for-service provision of primary care services. Nobody can make money in primary care that way. Hospital systems lose money on their primary care practices because they use them as referral feeders.
The specialists.
For higher dollar, higher margin, outpatient surgery, orthopedic, cardiovascular services.
Exactly.
Okay. So hospital systems can't even make money on their primary care. Okay, fine. CVS has had minute clinics and health hubs, which are arguably analogous to what Walmart Health and what Village MD were doing. However, CVS makes all of its money through its PBM. So the model is you get your prescription at your health hub minute clinic, you fill it at the CVS, and they're not even trying to make money off the pharmacy. We're like, okay, well, you fill it at Walmart or you fill it at the Walgreens and you make money off the pharmacy. No, the pharmacy is not where the money is made. And Walgreens and Walmart don't own PBMs.
No.
The money in pharmacy is made in the PBM. So the way that CVS monetizes its minute clinics and its health hubs is through the PBM. So now the final point I'll make is that risk-based primary care like ChenMed, where they're going at total risk for Medicare Advantage lives, they make money hand over fist over primary care. It's not fee-for-service primary care. It's total cost of care, capitated risk primary care.
On the capitated risk model, explain to the audience what you're referring to as it relates to physician reimbursement.
So in a capitated risk primary care model, and ChenMed's not the only group. There's other, especially in California, there's a lot of primary care groups that go at risk for their patient population. And typically the patient population is Medicare Advantage. And let's just use what the actual Medicare Advantage premium per beneficiary depends upon how sick they are and how many medical conditions they have. It's called risk adjustment. But let's just say on average, it's about $18,000 per patient per year. Okay. That means that primary care practice is doing everything it can to keep its members healthy and out of the hospital. And if it can deliver, and those primary care practices oftentimes can deliver their care, total cost of care. So like sometimes people need to get hospitalized, sometimes they get cancer, sometimes they need to have surgery, yada, yada, yada. But the total cost of care for those patients who are under that primary care model is only about $12,000 per year, which means that the primary care practice is keeping $6,000 per patient per year. Now, your typical primary care physician might see a patient like twice a year, and they're billing and they're getting reimbursed from like Medicare or Medicare Advantage, like $80 per visit. So your typical primary care practice is getting $160 per beneficiary, and ChenMed is getting $6,000 per beneficiary. And so the economic model for that is obviously infinitely more lucrative for ChenMed than it is for a quote unquote fee-for-service primary care. So primary care through traditional fee-for-service, yes, that economic model does not work. That does not mean that Walmart and Walgreens and Village MD are dumb.
No.
That just means that nobody can do it. So you should stop trying, okay? And all the primary care doctors that are actually successful, that are independent, they're going the concierge medicine or the direct primary care route where it's a subscription. And they're collecting $100 a month,
Correct.
$1,200 a year for somebody to be a subscribed patient, and there's no billing. So it can work, just not in the traditional fee-for-service model.
No, and I agree. So those folks are betting, literally and figuratively, that if we can take our members and keep them healthy and make certain that our cost is below the $18,000 and do it across the mean, then we will be in a good financial shape to pay for all of the administrative expenses and the staff and everything like that. So again, it gets back to what I've been saying for years. If you want to beat the healthcare system, stay out of it and just stay healthy from that standpoint. But the other thread I wanted to pull on with regards to CVS, and this coincides and is adjacent to the attempt by Walmart and Village as it relates to primary care. They have made 20 some odd billion or $28 billion investments in Signify and Oak Street. So it would seem that they are wanting to, not only because of the pharmacy is within 15 minutes of about 70% of the population, a CVS pharmacy, they want to bring the care into the patient's home, if you will, and then refer to Oak Street and then, do the whole model and have that control over that. Would that then allow them, since they own the PBM, to be able to have a larger patient feeder system, if you will, and then just continue to crank out the money machine?
Good question. And so this is where the overall model for how to basically make money in healthcare, we'll just call it the United Health Group model. Okay. Mm-hmm. And so all CVS is trying to do with Oak Street and Signify is they're just trying to play catch up with what United Health Group does with Optum. Mm-hmm. That's all it is. And so Anthem is doing the same thing, and Cigna is doing the same thing. And so all realized that, and because I talked before about the stock chart for Tenet Health. Again, look at the stock chart for United Health Group since the passage of the Affordable Care Act in 2010. Literally, the CAGR, the compounded annual growth rate of United since 2010 is the same as Apple's. Apple just started at a higher market capitalization, which is why they have like a $2 trillion market cap, and United's is still sub $1 trillion. But in terms of the CAGR,
a paltry trillion. What's a paltry trillion among juggernauts?
But the CAGR is the same. So keep in mind, United as a growth vehicle has been phenomenal. Okay. And so CVS and Cigna and Anthem aren't stupid. They're not trying to go in some other strategic direction. They're just trying to copy United's strategy.
Interesting. So I want to get back to your clinical days, and because I think the physician life, and it seems we're seeing a downward trend in number of physicians entering, or number of individuals entering healthcare at the physician level and nursing level. There's been a nursing shortage for at least the last 7 to 10 years. And I'm curious, does it ever seem, or do you walk out of clinic and say, God, this is incredibly difficult and frustrating because I just saw 35 patients today and I have no idea what I'm ever going to get paid for that. And there's too many hands in the cookie jar, and there's got to be a better way.
The physicians that are in certain specialties absolutely feel that way. And again, healthcare is very big. And
it's not all physicians.
Practices are very different. Okay. So even calling them all physicians is actually not accurate, because what they really are is they are their specialty. They are a cardiologist or they are a dermatologist. Okay. And actually cardiologists and dermatologists have very little in common. And they have very little in common in terms of the economic models of their practices. The economics of a dermatology practice and of a cardiology practice are like night and day. Like they're not even close.
Yep.
Okay. So they're hugely different. So to your point, are there physicians specifically in fee-for-service, primary care, pediatrics, family practice, in outpatient internal medicine? Disaster. Okay. Being an independent in those situations is nearly impossible, which is why they're all joining physician-owned hospital groups, because you have to, because the hospital systems that are able to make positive margins off their lucrative commercial insurance contracts for their facility fees. In other words, they do a spine surgery and they're able to collect 200 grand on it. And at the end of the day, it only cost them like 25 grand to deliver it. So they're able to take the 175 grand in margin from that spine surgery and then use that to partially pay for the salaries of the primary care physicians who can't even cover their own income, right? So there's that sort of internal cross subsidization that has to happen within a large hospital system. Now, there are other specialties like radiology, where radiologists are making money through the roof. Okay. I mean, now is a ridiculously lucrative time to be a radiologist. And so.
And what precipitated that?
What precipitated that is that there has been an increase in the amount of imaging that has been ordered, specifically in the ER. So the amount of so back when I did my training in the early 2000s, they never did MRIs in the ER. If you were to get an MRI, it either had to be scheduled as an outpatient or you had to be sick enough to be admitted. And then as an inpatient, you would get, you're concerned that you have a stroke, you get admitted to the hospital, you get the MRI as an inpatient because they're concerned you have a stroke, right? ERs now routinely do MRIs in the ER. So just for an ER visit, like my arm hurts, we'll get an MRI of your upper extremity, okay? And so what happens is that radiologists, when they read a film, okay, that has a certain number of RVUs, okay? And that number of RVUs, in other words, the amount of work that is quote unquote done, is actually the equivalent of what like a 20 to 30 minute office visit would be for a primary care doctor. And so, but that radiologist can read those films much faster. And so that when you add up the total RVUs in a year for a radiologist versus a primary care doctor will generate approximately 4,000 RVUs per year. A radiologist will generate 22,000 RVUs per year, over 5 times as many RVUs. Are they working 5 times as long? Are primary care doctors only working 10 hours a week and radiologists are working 50 hours a week? No. So the RVUs per hour are over 5 times higher for radiologists than they are for primary care physicians. And that's just the economics of radiology.
That's incredible. You brought up a great point earlier about the size of the healthcare system, and it's so multifaceted. So from a guidance standpoint, if someone is entering healthcare or has been in healthcare for the first 1 to 2, 3 years of their career, is there a specific area, whether it's disruptive technology, operational efficiency, clinical, is there anything that you would say, if I were you and you're looking to have this type of lifestyle or outcome or fulfillment or pride, satisfaction, gratification, what area would you shepherd them into healthcare?
Yeah, that's a great question. And the short answer is that the opportunities are nearly infinite. Again, because healthcare is 18% of the GDP, right? I mean, at 4.5 trillion, it has it's larger than like most countries in the world. It's like saying, okay, well, if you lived in Germany, what kind of job would you want to have in Germany? I don't know. There's a lot of jobs in Germany. You could have all sorts of jobs in Germany. You could pour beer. You could make Porsches. Like there's tons of different jobs you could have, right? So in healthcare, then the opportunities are infinite. Okay, so if you're like, some people are like, well, I'm a people person. Okay, great. Some people are like, I'm really not a people person. I'm a data person. Okay, like you name it, you can find a spot in it. Okay, now the question becomes, whatever spot you are in, what's the right way to approach that spot? And I will tell you my take on that. And my take on that is, whatever position you have, whether it's in administration or software development or direct patient care or research, the question you should ask yourself is the patient being put first? What can I do to put the patient first in my software? What can I do to put the patient first in my research? What can I do to put the patient first in my revenue cycle management consulting? And if you can because the essential problem in healthcare is that the patient is not put first.
Along those lines, and we mentioned earlier the Affordable Care Act, and probably one of the most recent large legislative pieces that passed was the No Surprises Act. And yet a large portion of the No Surprises Act, specifically around provider data compliance, attestation of accurate information, is designed to benefit the patient and or member, because the words seem to be interchangeable. And yet the adoption of the requirements, now going on 2.5 years, has been at a snail's pace. And there is still the member goes to the hospital directory or the physician organization directory, find me a doctor. The information is still inaccurate. A lot of folks say it says you're out of network when in fact I know you're in network. So if I love the optics and the lens through which we should be looking at is the patient first, it would seem that there's a huge opportunity for a lot of these folks to look at themselves in the mirror, and these organizations say, this is not helping our members. This is not helping the patient. And so why do you think the adoption of the No Surprises Act?
Great question. So anytime any industry does not put its customers first, it tends to be because there is a lack of competition problem. Let me give you an example. Moving companies. Okay? No one has ever had a good experience with moving. It's horrible. Okay?
Yep.
It is generally an incredibly infrequent service that you don't repeat very often. And so the moving company is not really incentivized to provide good service. Okay, let's use the flip opposite.
Good point. Yep.
Let's use the grocery store. Okay, the grocery store is awesome. Okay, the grocery experience in America is absolutely amazing. You walk in and there's literally 40,000 different items. You can have it delivered to your house. You can get in, get out. The produce is ridiculously fresh. Like when you and I were growing up, you could not get strawberries year round. You can now get strawberries year round.
Right.
It doesn't matter. No matter what, you can get it, right? Because it's a frequent service that has a lot of competition. It's very easy to go to a different grocery store, right? And so the problem with healthcare is that it's very infrequently used by people and there's not enough competition. And so the answer to making healthcare patient-centric is to make it competitive. And so healthcare is so dominated by such large organizations, and there's a lack of competition among hospital systems. There's a lack of competition among insurance carriers. There's a lack of competition among pharmaceutical companies because of patent protection for their specific pharmaceutical drug. Okay, so healthcare is not patient-centric because healthcare has a huge lack of competition problem. And people within these organizations are not going to be customer-centric out of the kindness of their heart. They will only be customer-centric when it is good business to be customer-centric. And when there is a lack of competition, then it's actually good business to not be customer-centric. So if you want healthcare to be more customer-centric, you have to dramatically increase the competition within healthcare.
Right. They're disincentivized. You know, and it's interesting. I do remember that growing up in the Chicago area in the 80s and 90s and 2000s. You're right about hospital competition back 25, 30 years ago. Because if so-and-so got a helicopter pad, then the hospital across town got a helicopter pad. If so-and-so got this trauma designation, then the other company or other hospital competing health system, they also needed to have that trauma designation because otherwise they were going to be pulling from their potential patient population. So how do you instill competition in the highly fragmented healthcare system of today?
So, right now we live in an in-between world where we both have a lack of competition and we have regulatory capture, meaning that the hospital systems and the insurance carriers have essentially won over control of the regulators, of the federal government and state governments. Okay. So the Affordable Care Act was meant to, quote unquote, regulate insurance. And then you look at the stock price of every single insurance company. The insurance industry won from the Affordable Care Act. Okay. The Affordable Care Act was the best thing that ever happened to the insurance industry. And it was meant to, quote unquote, put them in their place. So the Affordable Care Act is a perfect example of regulatory capture, where the insurance industry took what was supposed to be, quote unquote, regulation of them, and they turned it into a financial boon. Okay. So there are two things that you can do. You either need to go 100% with a state-run healthcare system, like most of the world has, or you need to break up the massive healthcare organizations, and the major hospital systems and the insurance carriers need to go through what AT&T went through in the 80s. They need to be broken up.
I was just going to say, what all the baby bells went through.
They're too bad. Yep. Okay. So everybody says healthcare needs to change. Healthcare needs to change. Okay. You can't change. Okay. So UPMC just laid off, quote unquote, 1% of its workforce. Okay. Guess how many people that was? It was 1,000 people. What does that means? UPMC employs 100,000 people. You mean to tell me you're going to change an organization that employs 100,000 people? There's no way. United employs 70,000 people. Are you going to change an organization that has 70,000 people? There's no way. These organizations are too big to be changed. You're never going to change them as they exist as behemoths. The only way they're going to change is if they're much smaller and they have to compete with each other.
Honestly, we could talk about these things for hours, and I would love to someday, but I do want to have you talk to me and us about Coupe Health. Tell me a little bit about that and the goals there.
So I, along with two partners, started a healthcare navigation firm called Compass Professional Health Services in 2007. And we grew that business to about 2,000 employer clients and about 1.8 million people that we helped navigate the U.S. healthcare system. Mm-hmm. And we sold that business in 2018. And we learned so much about how to navigate people through the U.S. healthcare system that we knew that we needed to actually be the carrier itself as the navigation engine. And so Coupe Health is actually a subsidiary of Blue Cross of Minnesota, where we have the navigation service baked into the insurance company so that there's not a separate entity that you use for navigation. We replace customer service at the insurance company so that you don't talk to healthcare, you don't talk to quote unquote customer service at the insurance. You talk to a healthcare navigator who literally is like, so you're like, hey, I'm Joe and I got this thing and I got this insurance. What do I do? And that's literally like 90% of the conversations that we have because people have no clue.
Correct.
Right?
Yep.
I mean, they're like, I don't know. And we had engineers, we had PhDs working at microchip companies. I mean, these people are smart and they're like, my name is Vincent and I got this thing and I'm a PhD in microchips and I have no idea what to do. Can you just help me? And so we bake that in to the insurance product and then we translate all of the complexity of the billing in healthcare and we take that away and we just translate it into copays so that it is 100% copay plan with zero deductible. So literally we give people a menu of what all of their out-of-pocket costs are in advance. It's like going into a grocery store where you can literally see the price of everything in advance. This is $10. This is $20. This is $50. This is $2,500, right? Because having surgery or having a baby is not going to cost $5, right? It might cost $2,500 to get your knee replaced, but at least you would know exactly what your out-of-pocket cost was going to be in advance, and you will never get a bill from a hospital. All you're going to get is the copay bill for the $2,500 from the insurance company, like a credit card bill. And that's it.
Interesting.
And so it actually, and guess what that's called? That's called normal. That's called what every other consumer experience in your life is like. And there's no reason why healthcare can't be like that.
And can anybody join?
You got to sign up for it through Blue Cross of Minnesota or other Blue Cross plans. And then we have a similar service that's on Aetna that's called Simple Pay.
Okay.
So you can get it on Blue Cross or you can get it on Aetna.
Interesting. And of course, who is Aetna owned by?
CVS.
CVS. There's very smart business people over there. All right, we're going to transition over to a very hot and featured segment. These are the speed questions and word association that we remember from our youth. So I'm going to mention a couple terms, and you tell me the first thing that pops into your mind. And it could be citizen Eric Bricker, Dr. Eric Bricker, co-founder of a company, of multiple companies. First thing, Payvider.
The future.
Interesting. We talked about this one earlier, but I'll say it again. No Surprises Act.
Meaningless.
Interesting. Digital front door.
Overhyped.
I would agree with that. And then lastly, the adult beverage conversation. If you could sit down and spend some quality time with someone inside of healthcare, living or deceased, to kind of have some meaningful one-on-one, who would that be and what are you drinking?
Richard T. Burke, the founder of United Healthcare, and coffee. As you can imagine, it's my favorite beverage.
Outstanding. It happens to be one of my favorite beverages as well. Dr. Bricker, this has been fascinating. I truly appreciate your kindness, your wisdom, insight, and the patience with which we got this all scheduled. It's been amazing. I encourage everyone to subscribe to A Healthcare Z. You will, as any great gift in life, I promise you, the amount of time you invest in that will be a 10x return in your knowledge. It's just simply amazing, very digestible, 8, 10, 12-minute chunks of wisdom that you can watch at any point in time. Is there anything else, Dr. Bricker, that you would like to share with the audience?
No. Martin, thank you for putting together this podcast, and thank you to all your listeners for tuning in.
Appreciate it. You're a hard act to follow. Keep producing that content. It's amazing. Thanks for inspiring.
Thanks so much.